Hello everyone, myself Dr. Deepak Khandelwal, consultant endocrinologist at Khandelwal Diabetes Thyroid and Endocrinology Clinic at Paschim Vihar, Delhi. So today I will be discussing one of the very clinically relevant case of poorly controlled diabetic woman with genital fungal infection. So this is one of the hypothetical case, 68-year-old lady who is coming to me after 3 months of follow-up, and she is currently on full dose of metformin plus empagliflozin 25 milligram once daily. Her glucose levels, they have improved from previous, but still glucose is not optimally controlled, and now she is complaining of itching in the vaginal area, and we have diagnosed vulvovaginal candidiasis, and she is also prescribed single dose of fluconazole 150 milligram. When her laboratory reports they are reviewed, her fasting was 150 and HbA1c was 8.2. Her previous HbA1c was 8.9. It has come down from 8.9 to 8.2, but still it's high. Renal functions, they are normal. She is currently on full dose of metformin plus empagliflozin. So what is important in this particular case? This lady is on metformin plus SGLT2 inhibitor. SGLT2 inhibitors like empagliflozin, they are wonderful drugs to treat type 2 diabetes because of pleiotropic benefits, good glycemic control, weight loss, good effect on BP, and good cardiovascular results. On the contrary, most common side effect of SGLT2 inhibitors are local fungal infection in genital area. Now, see, this lady is having mild vaginal candidiasis, and this risk is almost 2 to 6 times higher in persons with SGLT2 inhibitors as compared to without these drugs. And the common risk factors, if somebody is having poor glycemic control, female patients, they are more prone for these kind of infections, and if somebody has past history of these infections, then they are more prone for these kind of infections. Of course, as of now, this infection can be treated with local antifungal creams and single dose of oral fluconazole. But I think what is really important in this particular case, that she is still having poor glycemic control, and achieving optimal glycemic control is very, very important to prevent further episodes of such infections. So in this particular case, approach that I'm going to follow, I will continue the full dose of metformin. I will stop empagliflozin, and I will put this patient on fixed dose combination of empagliflozin plus linagliptin, because it is clearly demonstrated when we give this combination, of course, the glycemic control will becomes better. Probably she might have H1C less than 7 also in this particular case. Also, there's a clear data that when we use combination of SGLT2 inhibitors plus DPP4 inhibitors, in that scenario, the chances of local fungal candidiasis or local vaginal candidiasis or fungal valenitis, they are significantly lesser as compared to using only SGLT2 inhibitors. And there are a lot of mechanisms which are being proposed. One of the important mechanism is there's a local DPP4 enzyme that is present on the genital tract. And once you add DPP4 inhibitors like linagliptin, you inhibit that enzyme, so that when you use combination of EMPA plus linagliptin, the chances of these local genital fungal infections, they are lesser as compared to using only SGLT2 inhibitors. Also, one of the important mechanism can be because once they are on combination, they have good glycemic control. When the good glycemic control is good, the tissue hyperglycemia is lesser, and less tissue hyperglycemia can result in less local infections. So I think in this particular patient, I will continue full dose of metformin, and I will add fixed dose combination of empagliflozin plus linagliptin. And using this fixed dose combination also has a lot of advantages in clinical practice, because it is a single pill. Patients have to take just once in a day, any time of the day, irrespective of meals, very well tolerated, and the compliance is also significantly better. Thank you very much.